So hi everyone. Tonight we have another subspecialty VMR, and this time with pulmonary critical care. And we have two incredible guests, Dr. Gallo and Dr. Zhang. Dr. Gallo is an assistant professor of medicine in a pulmonary critical care faculty at Mayo Clinic Rochester. And thank you so much for coming, Dr. Gallo.
Thank you so much for having me. I'm so excited.
Yeah, so just a quick note that Dr. Gallo has been featured in a clinical problems solvers episode before, in which she shared authentic, practical, just inspirational insight into the IMG journey, and I highly recommend it. And I'll be posting the link in the chat later. And we also have Dr. Zhang, and she's a pulmonary critical care fellow at Mayo Clinic Rochester. And thank you so much for accepting our invitation, Dr. Zhang.
Yeah, thank you for having us. This is going to be a very fun night. Excited about it.
Yeah. So before we start the case, I would love it if Dr. Gallo and Dr. Zhang could tell us a little bit why they chose pulmonary critical care as a subspecialty and what do they do for fun outside of medicine. Why don't you go ahead first, Dr. Zhang?
Yes, I choose pulmonary critical care because I really like physiology and also just the spectrum of practice we can do within our specialty. And then mostly I think pulmonary critical care is also a very teamwork-based specialty, and I really like the multidisciplinary team-based approach to patient care. What do I like to do for fun? I like to travel, like to, listen to music, and then trying out different restaurants.
So what is your favorite food at Mayo, like in Rochester?
What?
What is your favorite food in Rochester?
Oh, I will say there is this Thai restaurant that Thai pop, yes. This recent opened a couple months ago of a Thai restaurant. They used to be like kind of a very small chef owned a place that was only doing like a couple kind of dinners every night. But now they have a restaurant. It's very nice. They change their menu frequently. So yeah, my favorite restaurant in Rochester.
Amazing, amazing. Why don't you go next, Dr. Gallo?
It's very hard to follow Dr. Zhang and be creative because we're pretty much have the same reasons to go into pulm crit. But for me, critical care is the team-based approach, is physiology. That's the only thing I know, I think, physiology. And if physiology doesn't make sense, it's very easy for me to make sure that we can fix the physiology. So those were the main reasons. And I also I really like internal medicine in general. So it was very hard for me to come to terms with the fact that if I chose something other than critical care, I would have to stop seeing like endocrine stuff, rheumatology stuff. So it's pretty cool. Like in a week in the ICU, you can have like new vasculitis presenting with hemoptysis. Like there was a CP Silvers a while ago on hemoptysis, and the same week you can have someone coming with DKA. So I couldn't choose something that I could live without. So critical care is internal medicine on steroids, plus you get to work with an awesome team and have learners. And I do a lot of things for fun because I believe in having fun. I run a lot, I exercise a lot, and those are fun for me, believe it or not. To me, it's not a chore, it's something that makes my heart happy. I hang out with friends. I love breakfast with friends, and I do that a lot. Thai Pop is probably my favorite restaurant in Rochester, but we have a really nice breakfast place called Benedict's. I like, people who know me know I could eat breakfast food for breakfast, lunch, and dinner every day. So I like Benedict's a lot too. But they are only open until 2 o'clock because they do breakfast and brunch.
Amazing. Oh, thank you so much for coming. So maybe we also have Madalena helping us with describing tonight. Maybe you can introduce yourself, Madalena, please.
Yes, hello everyone. My name is Madalena. I'm a medical student in New York, and I'm just so excited to be here with you all and learn from everyone.
Amazing. And we also have Andrea doing the teaching points. Why don't you go and introduce yourself, Andrea?
Hi, I am Andrea. I am a medical student in Peru, currently doing being a research assistant at Roswell Park in Buffalo, New York.
And without further ado, maybe Madalena, you can share your screen, please. And we can start whenever you're ready, Dr. Zhang.
Sounds good. I will share my screen now.
All right, sounds good. So we're going to have a case of a patient who presented with abdominal pain. And I changed some tiny details in the patient's demographics to kind of protect patient safety. All right, so she is a 45-year-old female. She's coming in for abdominal pain. A little bit on kind of the HPI. She has a history of hereditary hemochromatosis, which she has a homozygous type, and then fatty liver disease from alcohol use. She says that she has been feeling unwell for the past 2 to 3 months, just feeling very weak and unsteady on her feet. So on the day of presentation to the ED, which her family brought her over, she's been having some new constant abdominal pain for the last 3 days. She couldn't really locate where exactly in the abdomen it is painful. It's kind of all over the place. She also said that on the day of presentation, she had quite frequent falls, more than 10 times at home. Her son, who accompanied her to the emergency room, also mentioned that her eyes has looked yellow for the last 2 days. All right, so that's kind of our HPI.
So Dr. Gallo, you being a physician, when you encounter such a patient with such a rich history like this, what goes on into your mind?
So first I want to thank my good friend, Dr. Zhang, for probably bringing something liver related, because I'm obsessed with liver physiology. So I'm excited about this. And full disclosure, Zhenmei and I, Dr. Zhang and I had made a pact that I would not know the case. So this will be even cooler and funner for everybody. So 45-year-old woman, first things that come to my mind, again, hereditary hemochromatosis and fatty liver disease, 2 hits to the liver. But again, we have several other organs in the belly. Feeling weak and unsteady. A young woman feeling unsteady always makes me worry. In abdominal pain, have to think about kidney failing or something like that. With a chronic liver disease and chronic alcohol abuse and use, always have to think about something malignancy related in the abdomen that now is causing trouble, like HCC, hepatocellular carcinoma, sorry, HCC. And with falls, again, always have to think about something cardiological. Remember that in women, and I hope my friend Queen Isa is listening to me, like, so in women, chest pain, ACS, any coronary disease can present differently, right? So thinking about something cardiological, some arrhythmia of some kind, with the frequent falls. And again, it could be that this lady has actually some kind of pericarditis and now has RV failure, and that's why having abdominal pain and gut edema or something like that. A few things that I would love to hear. I know you said constant abdominal pain for 3 days, but I would love to hear if we know about the characteristics of the pain, and if there are any alleviating or exacerbating factors. Obviously, I know you said constant, but something that makes it better or worse. Are any medications have been tried? And eyes look yellow for the past 2 days. Again, makes me think about an acute obstruction of the biliary tract, that all of a sudden the eyes became yellow. But again, is it acute? Do we have any other things for chronic liver disease? Other important things, infections should always be in anyone's differential. So has this lady traveled? Has she eaten anything different? Has she tried a new restaurant with her chronic liver disease? Has she tried any seafood restaurants? Look, those are my first thoughts. Very winded, sorry.
No, it was brilliant. Yeah, so maybe you can provide us some more information, Dr. Zhang.
Sounds good. Yeah, and I think it's, like Dr. Gallo mentioned, at this point in a patient presenting with a pretty kind of you know, one complaint is having a very broad differential is always great in terms of before starting to think about next steps. So rather than kind of just because of her history of liver disease to focus on one organ system, still keeping it broad and focusing on multiple organ systems. All right, so a couple more things for her. So the abdominal pain is described as dull. She did not mention any alleviating or factor that's making it worse. The patient is also a little bit confused. She is, you know, oriented to herself, knows the date and, well, knows the month and the year, but with the situation, she's sometimes not very clear on the details. Based on that part with the exam. And then a little bit more about past medical history. She also has, so with her hemochromatosis, this was diagnosed 10 years ago when she had her gallbladder removed. And then at that time, they noticed some abnormalities of the liver parenchyma. So she had the liver biopsy at the same time. That showed diagnosis consistent with hereditary hemochromatosis. So she's being treated with just serial phlebotomy for quite a while until then she developed anemia. So that was stopped about 3 years prior to her presentation. She also has history of pre-diabetes. She also has depression and then some reflex esophagitis. Her last time with her history of liver disease, people ask if she has varices. So she had an EGD about 3 years prior to presentation. At that time, there was no varices. And then based on her last scan, it was just kind of more density in the liver, but she didn't specifically have cirrhosis. And then past surgical history was only the cholecystectomy that was roughly 10 years ago. She has not tried any medications at home for this abdominal pain. And normally for her meds, she's on duloxetine, she's on pregabalin, and she's on sertraline. She also has a PRN Ativan that was prescribed, but she has not used that recently.
Okay, so it just gave me a lot of things to think about. It really concerns me. So hereditary hemochromatosis, and for someone to become anemic, usually you need something else happening. So that already makes me think about something else that we need to think about, such as like the liver now is failing, kidneys are failing, bone marrow is failing for another reason. I know we haven't talked about labs and things like that, but again, wondering about other bone marrow failure. Reflux esophagitis, no varices, and you said that this was 3 years ago, the EGD also?
Yes.
So again, at that time, she didn't have any signs of portal hypertension, at least with esophageal varices, but that can be changed in 3 years. That can have changed in 3 years. Pre-diabetes, sure. Fatty liver disease. Again, this is a patient taking duloxetine and pregabalin, both medications, and sertraline, both 3 medications that are metabolized by the kidneys. So we have to think about some kind of kidney dysfunction also with these medications in her system. Someone mentioned infections as well, like I have mentioned before. So you mentioned no travel, you mentioned nothing unusual in that sense. And I would love to have some labs, but again, for CP Silver's purposes, do we have family history, social history, and allergies?
Yes. And then, sorry, I forgot to say, I don't know if she have tried a recent restaurant that was not documented.
Sorry,
but
just
not sure about. Yes.
I just thought about Vibrio and like maybe she went fishing with the liver disease or tried with liver disease. So just trying.
Not to our knowledge. All right, so I'll kind of complete the history part of things for her. Family history, no significant family history of liver disease. I'm not sure if other family members have been tested for hemochromatosis. that I didn't get to ask. All right, social history. She is still a current alcohol drinker. She drinks about 5 to 10 beers a day, and this has been the way for at least the past decade. She is a formal smoker. She quit over 20 years ago. And then otherwise, she lives at home with her 2 children and her fiance. Only allergy is to sulfonamides.
And before we go further, she still drinks. She lives at home with children and fiance. Is she depressed or something, that she might have taken extra things, that she might have tried to harm herself? Do we know any of that? Because
I don't think she has. The kind of, when I talked to the fiance, she has just been very sad and depressed for a long time, and drinking is kind of her outlet, her way of dealing with it, rather than she intentionally ingested any medication. Didn't seem like there was an acute change, but she has just been chronically drinking for a long time.
and is the depression the reason why she's on the sertraline, the pregabalin, and duloxetine?
It's for the duloxetine and the sertraline. The pregabalin, I'm not sure. I think there was some chronic pain she was having before.
Okay.
Yep. All right. And then before we go to labs, maybe we'll talk a little bit more about physical exam to try to kind of, narrow the differential a little bit based on our exam. So her vital signs, she's afebrile and she has no recent fevers either. Her temp is 36.3 Celsius. Her heart rate is 93. Blood pressure is 135/72, and then respiratory rate is 20, and then she's saturating 96% on room air. And this exam is when she is in our ICU. I don't have documentation on the initial exam when she was at the emergency room.
Can I ask you something, because it just came to my mind, and I don't mean to interrupt, for vital signs. Did we check for orthodeoxia?
We did not check for orthodeoxia.
Reason why I'm asking this, CP Solvers, is there are some liver lung diseases that will present with orthodeoxia. Do you all know what that means? Dr. Zhang, do you?
Yeah, it's sometimes with concern for patients, if they have shunting in the lungs due to their liver disease, then the position change can actually affect their oxygen saturation in that setting because you're having more shunting.
Yeah, so oxygen, and sensation of shortness of breath change in the upright position, and usually that is a clue for active pulmonary shunting. So sorry, I didn't mean to interrupt your friend.
Oh, no worries. All right, rest of the exam. So for general kind of HENT, she's jaundiced, she's alert, and she's oriented to herself and to the time, but not very clear on her whole situation. For cardiovascular, she has a regular heart rate and rhythm. There is a soft systolic murmur that's kind of heard over the upper sternal borders. Her lung exam is clear to auscultation, and she was on room air and did not have any accessory muscle use. Her abdomen appears to be distended. The liver margin appeared to be big, so there are signs of hepatomegaly, and it was slightly tender to palpation over the liver, and then she had no peritoneal signs on exam. On neural, only part of the mental status. There was no specific other signs. Someone asked about shifting dullness. That was not checked. And then extremities and the skin, she does have signs of chronic liver disease. She had some spider angiomas and then also pulmonary erythema that was noted.
So just one thing I want to ask you, for the murmur, do we know if this is a new murmur?
I don't know about that. I don't think it was I think it could be new. It didn't seem to be documented in previous exams.
And reason why I'm asking this for everybody is it's very important for us to know if it's a murmur, if a murmur is new or old. Like a soft systolic murmur Dr. Zhang said upper sternal border, but like someone who already had a history of anemia 3 years ago with hemochromatosis makes me think that this is probably just a functional murmur, especially in someone who's 45 years old. But again, I mentioned before that women with acute coronary syndromes and acute cardiac problems could present with different equivalents of chest pain. So again, and I those of you who have worked with me know that I'm not someone who anchors, but this is looking more and more something like acute on chronic liver failure to me. Again, confused. So at least grade 1 encephalopathy, but again, could be from other things. If she's anemic, people can be encephalopathic. If she's in shock, meaning that she's hypoperfusing for whatever reason, even though her blood pressure is normal and her heart rate is normal, if her lactate is elevated, or if we have signs of hypoperfusion, such as the kids or the fiance tells us she's not peeing for 3 days. And again, we know that her brain right now is not functioning very well. This could be as well shock. The systolic murmur again makes me think that that is either something primary heart driving everything, with again some kind of RV failure driving the liver dysfunction and everything that we're seeing. But with clear lungs, less likely, because for the RV to fail, the LV probably at this point would have had to fail a little bit as well. I didn't hear any ascites as of now, but shifting donors was not done. But if you can palpate the liver, probably you don't have massive ascites. No peritoneal signs. Neuro, I did not hear anything about asterixes or ataxia, so I'm gonna assume that those were either not done or were not there. And palmar erythema and spider angiomas make me think that this is chronic liver disease with something else happening. So I'm gonna put that highest in my differential. Why this is happening, I'm not sure. And another thing that you mentioned, she has been drinking for a long time. Didn't hear anything about binging. Didn't hear anything about changing alcohol preference, because that's very important for people to remember and ask. If someone who drank beer for their whole life and then all of a sudden goes to hard liquor, it might trigger new liver failure, new acute and chronic liver failure. What else?
You know, I think that's great.
I would love progressive dysfunction due to B12. Yeah, that's why I said, like, that's why I asked, like, I didn't hear anything about ataxia. I didn't hear anything about nystagmus. I didn't hear anything about perseverating or any kind of aphasia. So I'm going to assume that they were not there.
There was some mild asterixis, but I don't think anybody stood her up to check for ataxia when she was initially presented, and then not perseverating or anything.
So again, some degree of encephalopathy. And since I am an ICU physician, I would love to hear a point of care ultrasound. I'm wondering if that was done.
So a point of care ultrasound was not done on the heart, but it was done on the abdomen to check for ascites. And then it was very minimal amount. It was not safe for anybody to do any diagnostics or paracentesis.
And we didn't do like a subxiphoid since we were already there.
That I don't think anything was documented.
Sounds good to me.
Yeah.
I'll take it.
All right. And then I think, Dr. Gallo, has rightfully thought about this case, for acute on chronic liver failure. So for acute liver failure, that's mostly in patients who have no existing liver disease. But I think more commonly, we're seeing patients who actually have some chronic liver disease and coming in with acute presentation. So acute on chronic liver failure is kind of the diagnosis of concern here. And there's actually a very nice review that was written by by one of our co-fellows, Dr. Kinch, and then Dr. Gallo on the ATS core curriculum from 2020 that talks about acute on chronic liver failure and some considerations. So first, you have to think about why the patient is having something like this. What's the reason for presentation? The most common things are toxins and sepsis. So think about infection, think about any toxins such as, changing their alcohol or medications they take right now, about the trigger. And then the diagnostic criteria will also be thinking about extrahepatic organ manifestation. So what important one will be hepatic encephalopathy. And then like Dr. Gallo mentioned, this patient would probably qualify for at least a grade 1, and there are 4 grades. So grade 1 will be, just some mild confusion, some slurred speech, but overall they're still, alert. And then grade 2, they're moderately confused and there are signs of lethargy. And then grade 3, they're markedly confused, and then there's not very coherent. They're very sleepy, but you're still, may be able to arouse them. And then grade 4 will be when they're in a coma. And then in terms of critical care physicians, we think about whether someone's protecting their airway or not in those patients with encephalopathy. And if their GCS is less than 8 points, then you consider, then you should perform endotracheal intubation. So this patient on initial presentation, she was mostly a grade 1. She is still protecting her airway, so did not need emergent intubation.
Another tip for those of you also, if you are working in EDs and in ICUs, if someone can cough, that means that they're protecting their airway. So if you can tell them like, hey, give me a cough, if they can do a good cough, like they're protecting their airway and following command. So
yeah. And then Dr. Gallo, for labs, outside of the ones that are kind of listed over there for me to fill out, anything else you want to ask for?
I would love a good old lactate. Let me see what else. TBL. I would love a differential for Billy, not just total, if we have. And I would hope that you just told me that blood cultures were obtained in the ED, and I'll be happy with that for now. Again, to me, having a tox screen doesn't mean anything, but if we could ask, or if we could know if indeed this patient's pattern of alcohol intake has changed, or if she has taken something, again, someone who's depressed, even though it might have been unintentional, I would love a Tylenol level, just because, again, if we have one, or Tylenol is a very easy. Just a fun fact, in the United States, Tylenol can be bought in like big bottles at Costco and Aldi and things like that, and places like that. But in Europe and in South America, you have to pop the tablets from those like
blister.
Yes, thank you, from the blisters, and that was actually correlated with less deaths from acute liver failure from acetaminophen overdose in Europe and South America. So
all right. Yes, it's the same in China as well. I think US is the only place I know that comes in 2 bottles of Tylenol. All right, so for labs, so for hematology, so white blood cell count is 14.4, and it was predominantly neutrophils. And then hemoglobin is 10.4. That's about the same as it was last time she had labs, maybe 1 year ago. And then the platelet count is 165. So her sodium on the chemistry is 115. Her potassium is 3.8, chloride is 77, and then bicarb is 20. Her BUN is 6, and her creatinine is 1.68. This is slightly higher than the baseline, between 1.2 to 1.4. Then I don't have a glucose on it. I think it was in the 90s. It was normal. And then no ionized calcium to my knowledge. I don't have phosphor or mag. And then AST is 200 and 82. ALT is 124. Her alkaline phosphatase is 889. Total bili is 20.7, and direct bili is 18.5. Her albumin is 2.2. And previously, last time she was seen by hepatology was about 3 years ago when she underwent that EGD for varices. She at that point had normal AST, ALT, normal bilirubin. So her hepatic function panel did not look like this. And then I think the lactate Dr. Gallo asked for is 7.6. And her Tylenol level was undetected. The other thing I think in the setting of thinking about someone with acute on chronic liver failure is also coagulopathy that could happen. And then another important part in the calculator for some risk scores is their prothrombin time or INR. So that was 2.1 with a prothrombin time of 23, and normal is like I think less than 13. She's not on any medication that should increase her INR. And then the ED as their differential for abdominal pain, she also had a lipase that was checked, and this was 491, and the upper limit of normal for our lipase I think is around 100 or 110. Yeah.
So this is good. I am still thinking that the liver is failing here. Someone wrote on the chat box that elevated lactate could be from liver dysfunction. I wrote a paper about that, and actually you need to look at the trend. Just plain liver dysfunction should not increase your lactate. It does decrease the clearance. So careful with that affirmation. Whoever wrote that, I didn't see, but I saw that. That's incorrect. In liver dysfunction, the lactate doesn't get cleared as fast. Elevation of lactate acutely should still point you to other problems happening, to poor perfusion. So a lot of things here. So AST, twice ALT. So definitely her acute alcohol intake probably changed very recently. So alcoholic hepatitis still high in my differential. The alkaline phosphatase being so high with a direct T-bili makes me think that there is maybe something occupying the biliary tree that is not allowing bili to come out, so a cholestatic pattern. Tylenol level being undetectable, it's reassuring that she didn't take a ton of Tylenol in the last 4 hours. And this lipase elevated again, just drinking alcohol acutely can cause this, and chronic pancreatitis, which she probably has, but with the abdominal pain, then acute on chronic or acute pancreatitis is higher in my differential. And with this cholestatic pattern makes me think that maybe it was a stone that now is there lodged somewhere blocking the biliary tree, but caused pancreatitis on its way out. Those are my main thoughts after all of this. Her anemia right now doesn't explain her murmur to me, so I'm still paying attention to that murmur. Something is not right in her heart still, but still there. Her platelets being normal also makes me think that her synthetic function is overall pretty okay. However, her INR is high, and her albumin is low. But again, albumin being consumed could be just an acute phase illness right now. So not sure what much to make of all of that. And I confess that even though I love the liver, I always have to calculate a MELD score using a calculator, but this MELD score is not looking great right now.
Yeah, I calculated the MELD score, it's 34.
Thank you. I was going to say, I would say it's between 30 and 35 for sure, just because of some of the things, but I would need my MedCalc free calculator.
Yeah, the mortality, I think for 3 months was over 60% or something like that.
Yeah.
when I look at it earlier. Okay, so great, Dr. Gallo. And I think, you know, the one part about the frequent falls, why she's having it, partially could be the alcohol use. The other is her sodium is also 115. I think at the outside ED, there was one reading of maybe 112. So that was actually the main reason of her admission to the ICU, is in the setting of this low sodium and her having possible pancreatitis with, you know, fluid resuscitation and all of that, requiring very frequent monitoring. So that's how she initially came to us, but kind of the plot will thicken a little bit more later on. So for imaging, so she had a CT abdomen pelvis giving this abdominal pain and lipase. So I can share the 2 cuts that I got.
Beautiful. And do you have by any chance an ultrasound of her liver as well with Dopplers? Because I would love to see that.
So that was done, but I didn't screenshot them.
That's
so
all right.
I will share the results of that. So here's 2 cuts of the CT abdomen pelvis. And I know we don't normally read them very systematically compared to CT chest, but any comments on that, Dr. Gallo?
It's very generous liver. It's very big.
Yeah.
Is the her kidney looks okay. What is in her stomach? Did she have an NG tube already?
That I don't think so. At that point, no. So maybe it was like a pill or something.
Okay, because there's definitely something in her stomach. I thought it was maybe an NG tube, because that will, and very full stomach as well. So, and her pancreas does not look pretty. Her pancreas looks very angry. And like a lot of strain there, like, look, I don't know, I don't have control over there. Very, very strained pancreas, looks very angry.
Yes. So the main finding on this is acute interstitial pancreatitis. So for pancreatitis, the diagnosis, you know, you want 2 out of 3 criteria: clinical presentation of epigastric abdominal pain, or lipase greater than 3 times the upper limit of normal, or CT imaging findings. So she needs at least 2 for her abdominal pain, whether this is pancreatitis or due to her, you know, acute alcoholic hepatitis picture is unclear at that point, but I think she meets the diagnostic criteria for pancreatitis. Her bile ducts were a little bit generous on the CT scan, was commented. I think someone asked about that, but she did have a cholecystectomy previously, so the radiologist comment was maybe not out of proportion for what would be expected post-operatively. The other is that she did have a partial obstruction of a portal vein thrombosis.
And that's what I was gonna say. For a cirrhotic livers usually are small and shrunk, and this liver looks very big. So also makes me think about some kind of vein thrombosis with backflow. Also makes me think about RV failure with liver congestion. And also makes me think about some kind of lymphoma-like process, some kind of I'm missing the word that I want, infiltrative process. Yes, that's what I wanted to say.
Yeah, and I think for acute alcoholic hepatitis, the liver can be pretty big. It's a very inflamed liver in that setting, and it's you know, up to, I think some reports saying about 15 to 20% patients will have tenderness to palpation from the liver.
Yeah. And someone mentioned something about the sodium being too low for someone with chronic liver disease. Is not too low for someone with acute on chronic liver disease. Is actually very common to see this low sodium with acute on chronic liver disease.
Yeah. And then the sodium is part of the MELT sodium score. So having a low sodium is a very poor prognostic factor.
Bad.
Yeah. Anytime low sodium happens, you know, in heart failure patients with liver failure and then kidney failure, is not a good sign in any of the settings. Okay. And for her, there's probably some hypovolemic component as well, because it seems like mostly it's drinking and then not much of other eating. EKG showed normal sinus rhythm. She did have a chest x-ray that was clear lungs. Nothing impressive there. So based on this, she was diagnosed, I think, mostly with acute chronic liver failure and acute pancreatitis, also hyponatremia, and was in the ICU. So for acute any vitamin B12 exam, that was checked and that was normal. Like later on, a couple of days later. So for someone with acute alcoholic hepatitis, what are some things you think about in terms of management, Dr. Gallo?
So for this particular lady, the first thing that I would be very worried about, like you mentioned, like things that make me think she's also dehydrated, is how chloride deficient she is.
Mm-hmm.
So that makes me think that a little bit of her hyponatremia is probably hypovolemic hyponatremia. So careful hydration here. Acute on chronic liver failure, it's a very delicate patient population, because you have to address the cause. In her case, sounds like her acute decompensation is from her pancreatitis that led to a hyperinflammatory state that led to the portal vein thrombosis. And that makes me think that the pancreatitis obviously needs to be addressed first. So again, for pancreatitis, long are the days that we needed to give 10 liters to people. So gentle hydration, early food as early as possible. I didn't hear you say anything about stones. I know she had a cholecystectomy, but again, we could still have cholecystectomy and things like that. I didn't hear you say anything about stones. So we'll try to have her eat, if it's safe, as soon as she wants to, for the pancreatitis part of it. Her MELD is 34. So her 28-day mortality is above 50% for sure. So I would call also, if she is not in a transplant center, I will call the liver transplant team to see if she will qualify. She's 45 years old, to make sure that she has a quick pathway for a liver transplant in this case. Doubt that she would qualify, because at least in the United States, most states would not qualify someone for a liver transplant if they're still consuming alcohol, if they're actively consuming alcohol. And again, at this point, we could still say that this is alcoholic hepatitis on top of the pancreatitis as well. And use of steroids in alcoholic hepatitis is extremely controversial. Extremely controversial. There is several scores. The most accepted and most recognized one is the Maduri score. But again, very controversial, because the 28-day mortality is not changed if people receive steroids or not. And this patient on duloxetine, pregabalin, and sertraline, and chronic alcohol use is at high risk of alcohol withdrawal, and people can die from withdrawal of any kind. So very careful with being on top of any signs or symptoms of withdrawal. There was never a head-to-head comparison between single agents for alcohol withdrawal. I personally am a big fan of phenobarbital because it's very cheap, and I've been doing this for a long time, and I've never had to intubate anyone because they were on too much phenobarbital. So I'm a big fan of phenobarbital, but whatever you choose, either SIWA protocol or phenobarbital, or if you want to do dexmedetomidine, Precedex, it's okay, but make sure that you have something against seizures as well.
Yeah, sounds good. So for her, I think we did talk to hepatobiliary, which is one of our liver transplant teams, talking then, they were also thinking about, I think someone asked, differential for her pancreatitis, her triglycerides were normal, whether they're stone or not. So initially they were planning to do an MRCP, given that the bile ducts are a little generous. We didn't see any stones on the ultrasound or the CT scan, but something could be missed in that setting. So her Maddrey score for the acute alcoholic hepatitis was, I think, 60 something, 67, so very high. And I think for the Maddrey score, if it's greater than 32, then there's a potential benefit for steroids. But I think there was, for a lot of meta-analysis, the evidence is pretty poor overall in terms of that recommendation. And then there wasn't any mortality benefit. The other thing is some of these patients may not follow up after 1 month of steroids, and they end up being on steroids forever, which is also a risk.
Or they just stop it. And don't forget that patients with chronic liver disease also have subclinical, as a rule of thumb, subclinical adrenal insufficiency. And then we send these patients, because I don't know if people know, like, this is very important for us to say this. So if you decide to do steroids based on the Maddrey score, that means that these patients are going to be on a taper of steroids for at least 8 weeks. So again, they need to follow up. You need to make sure that they have a place to guide them in terms of tapering, because they might come back with fulminant adrenal insufficiency if they just stop and go back to drinking and forget to take it. So very, very controversial.
Yeah. And then for her sodium, she's coming in with, we don't know how long she's been having the hyponatremia. So in this case, we assume it's chronic. And then the rule of thumb is you don't want to correct it fast, right? So you don't want to correct it less than 6 to 8 within 24 hours. So for her, I think in the setting of this pancreatitis, we're basically giving a little bit of fluid, rechecking a sodium, and continue to monitor that. And thankfully, she didn't overcorrect. I think she corrected by about 4 in 24 hours. With that. And then the other thing for the Maddrey score and steroids is that one most important thing is ruling out infection. And I think Dr. Gallo mentioned blood culture that was obtained initially. And then with the hepatobiliary team, they actually wanted to start empiric antibiotics for her. So she was placed on Zosyn per their recommendation. And then there was talk about, if radiology can even try to do a diagnostic paracentesis when we didn't feel safe to do it at bedside, and then even radiology didn't feel safe to do something of that. So we had all great plans for this patient in terms of having MRCP, watching for alcohol withdrawal, and also monitoring her sodium and fluid resuscitation. But none of that happened because she acutely decompensated overnight. So when I initially saw her in the morning, she was still playing on her cell phone, talking with her family. The next morning I came back, she had a lot of changes overnight. So she had worsening mental status. I think she went from a grade 1 to possibly a grade 3, grade 2 to grade 3 on the hepatic encephalopathy scale. She was hypotensive. So initially her blood pressure was okay, but her MAPS was in the 40s. She had to be urgently intubated and started on vasopressor. So her norepi dose, I think, was at 1 point up to 0.2 mics per kilogram per minute. And then she was also started on vasopressin in that setting and stress dose steroids. When she was being intubated, they noted that when the cuff was inflated at that time, there was a lot of dark blood in the back of her throat. And again, she hasn't vomited any blood to anybody's knowledge, but it was noted at the time of intubation. And it seems to have been refluxed from the esophagus. So any thoughts on this after the acute change, and especially the concern for bleeding at this time?
So again, like we said before, I'm gonna stand behind my acute and chronic liver dysfunction here. We know 3 years ago she didn't have anything for portal hypertension, but again, both you and I mentioned how big her liver looked, how distended her vessels inside the liver looked. Someone said something about the spleen size. Very hard to measure the spleen in one cut only, but it did look a little generous to me as well. So maybe we missed portal hypertension when she first came in this time around, because she had nothing for portal hypertension at that time that we needed to worry about. And with the pancreatitis, and probably she was NPO for a few days and things like that. So she probably intubated, then blood, so stress, and that can always happen as well in acute critically ill patients. And it can decompensate chronic liver failure even further, and is the quickest decompensator of chronic liver failure actually is GI bleed. So probably the decompensation happened because she was slowly bleeding, and this is me playing Monday morning quarterback, slowly bleeding, decompensated, intubated. We put an NG tube and saw that ground blood.
Yes. So the NG tube to section had about 600 cc out, and it looked like coffee ground emesis looking. At the same time, I think right after she was intubated and had the decompensation, there was a call from the outside emergency room on her blood culture. So gram-negative bacillus was growing in 2 out of the 2 sets of blood culture. So her initial decompensation probably had some sepsis component as well. But at that point, she's already on antibiotics, and the infection is being treated. And right after the intubation, when she, was more stabilized by the team, in labs at that time showed a 3-gram drop in her hemoglobin. So it went from, I think previously was 10.4 to 7.4. Her platelet was still in the 180s range, and then her white blood cell count was 20. At that time, her INR has increased from 2.1 to 4.6. And her creatinine has also worsened. It was previously 1.68, now it's 2.19. And then we noticed that her urine output is also decreasing. The first day she made great amount of urine, it was over 2 liters, but after that, the urine output is decreasing. Her lactate also increased to now 9.8, and her fibrinogen is 178. So in terms of thinking about like GI bleeding and resuscitation, what are your kind of recommendations for goals of resuscitation from a blood products standpoint, Dr. Gallo?
Very love this question. So people bleed blood, so please give them blood products. Do not, fluids are okay for a little bit, but if they're throwing up blood, they need blood products. It depends what you tell me the EGD shows. If she does have portal hypertension, then you should be less liberal with your hemoglobin. So 7.5, less than 8 is like most of the most recent studies on acute and chronic liver failure from GI bleed from portal hypertension and varices. If she doesn't have any variceal bleed, no stigmata of that, you can do like 8. But no need to go above that. And balanced transfusion, the best thing for this patient, for any bleeding patient, if I can have this as a take home. I am sure someone is going to mention TEG. TEGs for guiding transfusion have been validated currently for liver patients during liver transplant or being evaluated for liver transplant, for any cardiac surgery on pump, so on extracorporeal life support during the surgery, and also for massive trauma in the ED that you're giving a lot, that you're basically exchanging one's volemia. With liver patients, like this patient, acute and chronic liver patients, what they need is blood products. So if you do balanced, you won't go wrong. So PRBCs, FFPs, platelets, and cryoprecipitate.
Sounds great. So for her, yes, when she had this acute decompensation, I think even though her hemoglobin was still above 7 on the initial check, there are signs of continued bleeding and she was in shock. So she actually responded well to blood transfusions. She also, I think other things we think about, with the balanced transfusion protocol, you also kind of monitor some of the other markers. You can look at, for her INR is elevated, so of course she will need FFP, but the fibrinogen, sometimes the general rule is less than 150, they will likely benefit from cryoprecipitate. Her platelet eventually, I think, did drop, so sometimes in the actively bleeding patient, you want their platelet to be above 50, sometimes above 100 in those cases. The TAG or TEG, thromboelasto something?
Thromboelastogram.
Elastogram, yes, that's what it stands for. That is one way to kind of check the cascade of coagulation, and that can guide you. We did check it on her, but it didn't really tell us anything new beyond what we already know. That we know she needs products, it's telling us exactly what she needs. The only thing that was normal was like the 30-minute lysis time, which says she does not need TXA. So, and her EGD, she at that time had grade D esophagitis. There was basically blood in the whole esophagus. There was blood in the whole stomach. She did have signs of pretty severe portal gastropathy. So even though there's no varices, there's signs of portal hypertension, and it was just diffusely oozing the whole time. So for her, a more conservative approach is appropriate given the portal hypertension that's evident. So this patient, I think, is in acute home chronic liver failure. And at this time, this is liver failure affecting multiple organ systems in terms of her mental status, the brain, and then her renal function continued to worsen. Her creatinine uptrended to over 3. She was also having ongoing coagulopathy. I think even after the EGD, she continued to bleed. Her hemoglobin would drop and she would become hypotensive. So I think in total, she got like over 10 units of PRBC and like 5 units of platelets over the next 48 hours. And I think in these patients, the biggest thing, like Dr. Gallo mentioned, is being at a liver transplant center and talking about whether she's a candidate for liver transplant or not. So alcohol use, there is controversy of current alcohol use and whether they could be a liver transplant candidate or not. But in her case, we were told that given that she has prior liver disease and the knowledge of that liver disease and continued alcohol use on top of that makes her not a candidate. Oh, someone was going to say something.
No, I said that makes sense. Sorry, I was thinking out loud. Yeah.
So for her, I think I'll just kind of say the rest of her clinical course. I think with the not being a liver transplant candidate in fulminant liver failure, our conversation with her family was eventually she was transitioned to comfort cares and then passed away on hospital day 5.
Yeah. So unfortunately, is the right thing to do. This 45-year-old woman with clearly chronic liver disease with, again, we knew after the fact that she had portal hypertension, but continued to drink, had a stone, probably stone, acute pancreatitis. Probably she had a GI source for this bacteremia, gram-negative bacteremia. She maybe was already oozing, and that was maybe the translocation. But again, with a albumin of 2, she could have very easily had bacterial translocation. Multi-organ failure, best supportive care sometimes is not enough, and it's the right thing to do. We sometimes can't win.
Yeah, without a new liver, all the problems just cannot be reversed. And then with her kidney failing at that time. As well. So for patients with hepatorenal syndrome, if they have renal failure secondary to liver failure, dialysis is mostly considered if they're going to be a transplant candidate as a bridge. So if they're not a transplant candidate, then dialysis in that setting is kind of means to nowhere. So I think sometimes, limitations of what we're offering to patients and their family members to think about, the next steps afterwards. She can be on dialysis, but that's not going to reverse the underlying process. So that at the time we talked, they didn't think she would ever want one anyways.
Yeah, and very important, hepatorenal syndrome is also a diagnosis of exclusion. So in someone with bacteremia and pancreatitis alone, just those two alone, we could not call this hepatorenal. We should treat this as acute renal failure from ATN, probably from intrinsic lesion to the kidneys, not necessarily from the liver dysfunction. So we should focus on treating the underlying causes here. And then if we can fix all of those and the kidneys are still failing, then we can think about hepatorenal. But regardless, Dr. Zhang brings up an excellent point that if someone is not a transplant candidate, then offering dialysis is a bridge to nowhere.
And then, yeah, thanks for the reminder. Yes, in patients receiving a lot of blood transfusions, always give calcium. Sometimes I don't even check. I just give calcium after, they get a couple units of blood, because that the calcium will be low. And then hypocalcemia can also contribute to hypotension in these patients.
And rule of thumb in the ICU, if someone received 3 units of PRBCs or more, you just give them 2 grams of calcium gluconate or 1 gram of calcium chloride.
The patient was on Zosyn for her antibiotic.
Thank you for coming, Dr. Wagner-Whipple. She's one of my mentees, so it's very cool that she's here. Does anyone have any questions? This is amazing. This is amazing case. Thank you, Dr. Zhang.
Thank you, Dr. Gallo. I think you want a liver case. This is a whole spectrum of liver case.
I love the liver. Does anyone have any questions? So take home points. I love take home points if you guys want to hang out with us for a few more minutes, but very important things that sometimes we don't think about. So acute on chronic liver failure, best care first and foremost is best supportive care. Calculate their MELD score. If it's 18 and above, start thinking about sending them to a liver transplant center, capable center, or at least evaluated. Think about causes of acute on chronic liver dysfunction. So like we said, infections, drugs, exposure is very important. Any new drugs, changes in patterns, and obviously pancreatitis is one of them, one of the causes. Think about something major such as heart failure for whatever reason, ACS or not, and make sure that if they have any signs of portal hypertension and they are bleeding, that you are less aggressive with your hemoglobin and your blood pressure parameters, because that will just keep perpetuating bleeding if we over resuscitate them. Rule of thumb from an intensivist: if you gave 2 or 3 units of blood, make sure that they get calcium. Don't wait for the results to come back. Yes, ICU is amazing. Don't wait for results to come back, just give them calcium. And don't forget that if people are bleeding, they need blood products. Fluids are great for temporizing, but you're just gonna make them more diluted, and you're gonna make their clotting factors or clotting ability worse. And please love the liver. The liver is the best. This is pure physiology, just physiology. And critical care is the best. Do critical care. All of you just go do critical care. Is the best.
Oh my God, I feel like a lot of people go to critical care after this discussion. Thank you so much, Dr. Gallo and Dr. Zhang. Such a pleasure, such an honor to have you both here. We learned so much, and I guess, and I'm sure a lot of people learned a lot with you. So thank you. Maybe we can finish the session off with Andrea with the teaching points.
Thank you. We started by remembering that women with acute heart disease can present differently because the patient have acute ictericia. We talk about acute obstruction of the biliary tract and infection like Vibrio. And something to have in mind in patients with chronic disease that luxetine and pregabalin are metabolized in the kidney. Something that I never heard before, I learned today, is that orthodoxia is dyspnea induced by a right posture and is a clue for pulmonary shunting. If you can palpate the liver normally, there is not a massive ascites. And more and more patients are presented with chronic disease or an acute presentation. In the case of liver, it can be a toxin, like change in the type of alcohol or medication, sepsis, or as a critical care doctor, you have to think about the protection of airways. As a rule of thumb, the patient can cough. There is no need to intubate the patient. Then there is this CON score that is used to grade the hepatic encephalopathy, with 1 being lack of awareness, 4 being coma. Another thing to know is that plain liver dysfunction does not increase lactato per se. It just not clear lactato as fast. Acute alcohol intake can cause elevated lipase in the setting of previous chronic pancreatitis. And cirrhotic livers tend to be are usually small. You feel like they are shrunk. And some generalities for the management of pancreatitis, gentle hydration, and food as early as possible. Dr. Zhang and Dr. Gallo talk about the MEL score. The MEL score is a model for end-stage liver disease and is a predictor of survival in patients with cirrhosis, alcoholic hepatitis, acute liver failure. And as a rule of thumb, if you give 2 or 3 units of blood, you should give calcium without even waiting for the labs. Thank you very much.
Thank you so much, everyone. Hope to see everyone tomorrow. Have a very good night. See you.
Thank you for having us.
Thank you for coming.
Thank you for having us.